I will share this screen. It works okay?
Yes.
Yes,
We can.
perfect. So today I will talk about different modalities of vascular access, mainly focusing, as you said, on patients who need red cell exchange. I would like to begin this session by presenting a clinical case because this will help us to focus on the topic. This is an 18-month-old boy with sickle cell disease who was referred from another center, and he was admitted there for a vaso-occlusive crisis complicated by splenic sequestration in the context of influenza infection. He was also admitted to the intensive care unit for a possible acute chest syndrome. And then the clinical team requests us an urgent red blood cell exchange. So, as you know, there are several therapeutical options for sickle cell disease, and many of which require venous access, from simple transfusion or red cell exchange, but also curative treatments such as stem cell transplantation or even gene therapy. And to understand these requirements, I think we need to know more about of these procedures, the red blood cell exchange. So, for what reason should one treatment modality be selected over another? Here in the table, you can see the advantages and disadvantages of simple transfusion, manual exchange, or automated red cell blood exchange. And as you all know, a simple transfusion is easy to perform, does not require experienced personnel, and is not expensive. However, it increases the risk of hyperviscosity and also iron deposition. And it's also not very efficient at lowering hemoglobin S. So manual red cell exchange is less effective than automatic modality at lowering hemoglobin S, and does not eliminate the risk of hyperviscosity and increased iron deposition. So automated red cell exchange is fast to perform, is efficient, and has benefits in terms of iron balance and hyperviscosity. But it also has disadvantages, of course, and include the need of trained staff, costs, as well as the historical consideration for central venous catheters in some centers. But I think it's not a problem today. We are going to discuss this topic. And it should be noted that several studies have found the transition to automatic exchange to be cost-effective, and that several expert panels recommend this option over other options. So, what are the indications levels of evidence, indications and levels of evidence for red blood cell exchange in sickle cell disease? To answer this question, we must consider the 2023 American Society of Apheresis guidelines that we use all days in our unit, and the table shows both acute and chronic indication. As you can see, in the acute setting, there are many indications: acute stroke, several acute chest syndrome, and also other complications. In the chronic setting, the focus is mainly on perioperative management, recurrent vaso-occlusive crisis, and stroke prophylaxis, and the stroke prophylaxis has the highest level of evidence. But what are the logistical requirements for implementing a red cell exchange program? I think it's a very important thing is that for implementing a red cell exchange program, we need a multidisciplinary approach. And our hospital is a reference center for hemoglobinopathies, and we have a regular committee meetings and also a consensus protocols. And sorry, and these meetings are attended, as you can see, by different specialists from both adult and pediatric departments. And I think it's very, very easy to comment to patients in these meetings. Once we make the decision to perform a red blood cell exchange, we need different things. We need to review the clinical history and verification of the correct indication. We need a request for the procedure that must be made by the clinical team. The patient and or the family members must sign the informed consent. And we also need the weight and size of the patients, the transfusion history, an extensive phenotype or genotype, and also the last hemoglobin S. But also blood tests, including hemoglobin, platelets, coagulation profile, biochemistry, and also the hemoglobin S pre-procedure. We also need the transfusion request and the pre-transfusion sample. But finally, but not less important, we must assess the venous access. It could be peripheral ultrasound guided or central venous catheter, and also we need trained staff. It's very important. There are pediatric apheresis considerations. So you know that the machine itself requires an extracorporeal blood volume of approximately 185 milliliters, and it's estimated that the maximum allowable value in children is from 10 to 15% of the extracorporeal volume. So, as you can see in the example on the slide, a 10 kilograms child will always require the machine to be primed with allogenic blood. To prevent closing of the circuit, anticoagulation is necessary, as in other apheresis procedures, and we usually use ACDA. As you know, one of the main side effects is hypocalcemia, and symptoms sometimes are difficult to be detected in children, so we have to be more vigilant in these cases. And also, sometimes we need blood warmers to avoid hypothermia. And another consideration, of course, is venous access, which depends on age. Just to be able to understand the process better, we will program the device according to the desired parameters. We will need a pre-procedural hemoglobin S level, which is usually estimated based on previous studies. And the desired hemoglobin S level is approximately from 20 to 25%, but it can be lower in some acute events or even in cardiac surgery. In general, the desired hematocrit afterwards will be 30%, and in the chronic program, the frequency of procedures is usually every 4 to 8 weeks. So once we understand the procedure, we will go into general consideration of venous access modalities. And the requirement for a venous access, it's important to know that it's not an infusion, it's an apheresis process and are completely different. And this is the first thing to consider. In general, optimal and uninterrupted flow is required, and pressure alarms must be avoided, because if not, the procedure doesn't work. And of course, the peripheral access must be prioritized to minimize complication, as always. And the characteristics of the procedure must be taken into account, including, of course, type of procedure, the desired flow rate, the frequency of the treatment, the duration of treatment, or even the level of urgency. But not also the procedure. We must also consider the patient's characteristics, for example, vascular anatomy, age, or general condition, and also important, our hospital. We must consider what our hospital is like in terms of expert professionals and also material or economic resources. I think it's important to know it. I have to say that the real experts in this field are nurses, not doctors. But in general, we can say that we need a straight, firm vein, and we should prioritize palpation over visual appearance. Um, and if no viable access are found, we can perform an ultrasound visualization to allow cannulation of the deepest vein. And the assessment of venous access, of course, will be recorded in a register, and I think it's a good thing to record in the patient's clinical history. So let's go into a little more detail. At an academic level, there's a series of physical factors will define the flow rate. Here you can see. These factors take into account the pressure difference between the inlet and outlet needles. So we can say that good veins will give us more flow. Another important thing is the radius of the needle. It's also important. Doubling the needle gauge multiplies the flow rate by 16 times, for example, and also the length of the needle. Flow decrease with longer needles. And also important, blood viscosity and hematocrit levels, because all of them plays a role, important role. And the higher the viscosity, the lower the flow rate. So I think it's important. The veins in the cubital fossa are better candidates for extraction. And as you can see in this image, there are different patterns of superficial veins. And in these pictures, it's very clear, but I think it's not the case in our patient, of course. So sometimes it's more difficult than in these pictures. And there are two important factors for me for venous access, and despite their simplicity, these factors are very important. One is cold that can cause vasoconstriction, and the other is anxiety or fear. And what can we do for our patients? We can reduce the sensation of cold by regulating the room temperature and applying local heat. And I think it's a very important thing and very simple thing that we can perform in our apheresis unit. And also it's important to reduce anxiety by creating a friendly environment and by informing patients. And of course, in some cases, the administration of an anxiolytic may be also necessary depending on the patient. As you can see in this slide, the thickness of the needles and the theoretical infusion flow rate are shown, but clearly there are other factors to consider, such as viscosity of the blood and the type of vein. We have commented these things before, and in our experience, we typically recommend the 18 gauge needles for extraction and 18 or 20 gauge needles for return. But the flow rates are not 70 to 80 milliliters per minute. Is lower, is really lower in red cell exchange. And commercial companies will provide, as you can see in the slide, the information of these devices on gauges, theoretical peak flow, and also outside and inside diameter. So it's important to know that we can see in the information provided. There are not many studies specific to a rare disease, and I would like to highlight a study by our colleagues in Hospital Clínic of Barcelona, and they conducted an experiment with different needles, and they concluded that although 16 gauge needles provide the maximum flow rate, many procedures can be performed using smaller needles, and I think it's a very important thing. They also concluded that with higher hematocrits, the flow rate is much slower. The second study, involving 26 patients, found that the use of 20 gauge fenestrated cannula was not inferior to a conventional 18 gauge needle, and there are no specific studies on hemoglobinopathies. So when choosing peripheral venous access, we need to consider whether to use plastic cannulas or metal needles. Plastic cannulas carry a lower risk of extravasation and are more comfortable for patients. But metal needles are less likely to collapse during extraction, so sometimes we prefer this kind of metal needles if it's possible. And there are also other problems that can occur, and one of these problems is pain. To avoid this, we can use anesthetic creams, and some studies have observed that the application 30 to 60 minutes before can be beneficial. And we use EMBLA cream, as you can see in the slide, and I think it's a good option for some patients. As for hematomas, a good cannulation and extra compression are recommended, of course, in case of hemostatic alteration of the patients. And if the procedure has to be stopped for a venous access obstruction, salinization is also recommended, as you all know. But the introduction of ultrasound-guided access, I think, has completely transformed the apheresis units in recent years. It's a very good thing. And there are, as you can see in the slide, there are several studies that have shown a reduction in the need of central venous catheters. So I think it's a good thing in the apheresis units. Some specific studies have explored the use of ultrasound-guided venous access in patients with sickle cell disease who require transfusion support or exchange transfusion. The first study you can see here in the slide, although cannulation was slower because it's a more you have to use the ultrasound-guided device. It was less painful and improved patient satisfaction. So I think it's important. And this study was addressed in pediatric population. The second study you can see achieved a mean flow rates of 45 milliliters per minute. That I think it's a very good flow rate in these patients. Now we are going to talk about venous central catheter. As for temporary central venous catheters for acute processes, as you all know, femoral access is easily accessible. However, it has a higher thrombotic and infectious risk. The jugular catheter is therefore preferred in some units, as it has the fewest complication, and which we use jugular catheters more than femoral catheters. In this image, you can see the recommended size according to weight in French, depending on the kilograms of the patients. And regarding indwelling catheters, as you all know, tonal catheters are generally not useful in this context, and implantable devices, ports with a reservoir are preferred. it's obvious because these are more comfortable for patients in the chronic setting. As you can see in the slide, some models are used in apheresis, but they are not especially designed for apheresis. And models from angiodynamics have been widely used due to their dimensions, but they do not always provide the desired flow rates. And although there are devices designed for these procedures, for example, Titan port, I think it's too big and is not useful for children, for example. Some specific studies have been conducted on this population. As you can see, the first study compared the vortex and bar ports, and the flow rates, as you can see, is almost identical. And also fibrinolytic pretreatment had no positive effect. The second study involving a dual lumen port found that the pediatric population had a lower inflow velocity than the adult population and fewer pressure alarms. But what is clear is that these port devices needs periodic review, with many centers routinely performing pre-procedure orokinase treatment, and sometimes we have technical difficulties in terms of flow. And it's a good option, but it's true that we have sometimes problems in the flow rate. And what has been our experience in our hospital? So I'm going to explain our experience. The first cases of rectal exchange and acute complication were in January 2017. And after a year, we conducted the first in vitro studies with different ports to select the most suitable one. And the chronic program began in February 2018. Here, together with Dr. Velasco from Pediatric Hematology Department, we performed some experimental studies with 3 double lumen ports and 1 single lumen port, as you can see in the slide. And the results were presented at the European Hematology Association Congress. And the catheter that produced the most favorable results, the most good results, were those manufactured by AngioDynamics. In these catheters, we use 19 gauge gripper to achieve a flow rate of 25 to 30 milliliters minutes. And finally, we selected the 6.6 French single lumen port to be the most suitable for our pediatric patients for the following reason. The smaller reservoir, more suitable for these small children. And also at the beginning, when there was not the option of single needle software, the option was 2 separate devices that allow replacement if only 1 lumen was necessary. And of course, a single lumen could also be sufficient for single needle software. So in April 2018, we began using the single needle software and conducted an evaluation of the red cell exchange program for all patients between 2017 and 2021. As you can see in the table, most of our patients were pediatric. We performed a total of 126 pediatric procedures, and most of which were chronic indications, and most of these also were performed using a port device. And as I said before, once the single needle software was available, it was implemented in our patients, and it should be noted that the average extraction rate was approximately 30 milliliters per minute. That is, I think, it's a very good thing. And that the procedure takes longer, of course, if the dual needle modality is used. Then the ultrasound guide venous access program was implemented in our unit in 2024. Two of our nurses underwent training in other hospitals. And I have to say that although it has taken time to become fully autonomous, now we have 3 nurses that can perform this procedure, as you can see in the slide. And at the end of 2023, we presented our cohort data at the International Blood Transfusion Congress. It was, of course, a multidisciplinary project in which we analyzed our experience over 7 years. And a total of 35 patients were included in the study, 26 of whom were pediatric. And the procedure was performed in the acute setting on 27 patients, and 9 were included in the chronic program. And with regard to the patient's characteristics, you can see in the table, but I would like to point out that we have treated patients with a weight as little as 9 kilograms in this cohort, but I have to say that in fact a procedure was performed on a 6 kilogram girl last year, so it's our limits. And in the image, you can see also the main indications in the acute setting: breast surgery, multi-organ failure, stroke, splenic sequestration, and also acute chest syndrome. And for chronic red blood cell change, of course, the procedure was indicated in most cases for recurrent vaso-occlusive crisis or intrahepatic cholestasis. In total, we performed 300 procedures. Most of the acute procedures were carried out using central venous catheter. And for chronic procedures, we use ultrasound guided venous access for adults and single lumen angiodynamic port for pediatric patients. We use also single needle modality and blood priming in single needle modality in 62%, and blood priming was necessary in 15% of the procedures. And about venous access, minor flow problems were observed in 11% of acute cases and 12% in chronic cases. And only 3 apheresis procedures were unsuccessful due to a flow problem. About follow-up and side effects, all patients showed a clinical improvement, and I have to say that in the chronic exchange program, 33% of patients reported even a disappearance of crisis. I was very happy about this. And side effects include 1 mild allergic reaction, 1 possible hypocalcemia, and 1 hematoma at the puncture of this side of the port. So we think automatic exchange program with these venous access options is a safe and effective in this setting. And what happened in the last year? I have to say that the number of patients included in the program has increased. And if we look at 2024 in numbers, as you can see, we treated 20 patients performing 128 procedures. And the slide shows the distribution according to age, and only 5 procedures could not be completed due to flow problems. We have to say that as children get older and have used the port device for years, we cannot perform the apheresis at a very fast speeds, and also we have to process more and more volume, so sometimes it could be a problem. But in conclusion, we have to say that the venous access options that we are currently considering in the chronic context of these patients are ultrasound-guided venous access in adults. For adolescents and young adults, the options are ultrasound-guided venous access or a port device if the children has these options. And also for children, a single lumen ports are also used. And that's all. I would like to thank the pediatric and adult hematology department, also the transfusion service, and of course, in particular, the nursing team, the nurses team, with expertise in red cell exchange procedures and also the ultrasound guided venous access. And thank you all very much for your attention.
Thank you very much. That was a really nice presentation. You presented us some really nice information. Does anyone have a question? Perhaps until we get some questions from the other people in the webinar, can I ask, what is the
Yes.
time window when you receive some patient with acute
Yes.
episode to perform until you decide and perform the cell exchange, red cell exchange?
Yes, we can perform even in the night or in the weekend. We can perform this type of procedure. Yes, so it can be an urgency. Of course, the hematologists, also the pediatric hematologists and the blood bank hematologists have to decide the urgency of this procedure. But if it is an urgent procedure, we can perform in a few hours.
Is there any common challenges you face with hemoglobinopathies patients, for instance, not having access to their latest tests or anything like that? Like you found a pattern? Is there any specific challenges?
Uh, for me, it's the compliance. I don't know how to say, because sometimes in the chronic program, there, I don't know, it's because the social environment or the problems, the social problems. Sometimes they are not conscious about the illness and they are not going to the procedure. Sometimes I think it's a challenge for us because we have a regular procedure every 4 to 8 weeks, but sometimes they don't. I don't know why they don't go to the hospital
They don't
because
come.
they forgot, or perhaps they have an exam and they don't come to the hospital.
I see. Thank you. Does anyone else have a question from the audience? Okay, thank you very, very much, Dr. Pons. That was a really nice and interesting talk. It was interesting to see that there's no studies in hemoglobinopathies patients, so perhaps something for the future. Thank you, everyone, for joining us today and wishing everyone a nice afternoon.
Thank you very much. Bye.
Thank you.
Thank you.
Bye-bye.
Bye.